It's really a pleasure being back in this room. It seems like I never left. But I would really like to take you through a journey of our research, what we have done so far and where we are going from here. My group, nobody that is not here, they're all busy relatively, so it's going to be me talking. Oh, yes, from anesthesiology. So I'm going to start talking about AKI from the other side of the rainbow, meaning how intensivists, right, see AKI. Maybe show you that side, because you know, I end up being on the both sides. So I'll start with the disclosure with my grant that I have. I also had the support from the Acute and Etox Bio that were working on development of biomarker, as well as Society of Critical Care Medicine. And my major bias is really that I'm both nephrologist and intensivist. So as a critical care nephrologist, I think I have synthesis of both worlds. Learning objectives will be to identify importance of the kidney health, describe some evidence behind the use of biomarkers current, and also see how we can use them in a clinical practice. So I'll start with the key points, and I think for this audience, it's not going to be hard to convince you about these points. It's not always very intuitive for people who are not nephrologists. The first is that acute kidney injury is one of the most common hospital complications with lasting consequences, that kidney health must be assessed at hospital admission using history, estimated GFR, and urine dipstick at the minimum. AKI should be diagnosed and staged using consensus criteria. In 2016, we hope that. Kidney can acutely suffer from many different causes, and primary prevention is really the key at this point, in my belief. So when my friends, nephrologists, give talk on AKI, they always show this very complicated picture about etiology of AKI in ICU, right? And you can see that there are many factors. Now, when you are in ICU, you see this. You see 80-year-old man after Whipple surgery who had history of CKD. His admission creatinine is slightly above his baseline of 1. It's 1.26. He came to your ICU. He's making little urine for 3 hours. Now, how do you take that picture now? He has exposure of hypertension, nephrotoxic drugs. What do you do for this guy? Do you give him fluid? Do you give him diuretic? Do you extubate him? How is his kidney doing? Like, you really are faced with a case that all complexity doesn't help you, right? So that's something that we are faced every day, and how you go backward, and how do you now train people to do properly in those situations. So we started backwards thinking about, is AKI common? Is it important? How can it be diagnosed, and how can it be treated? So AKI is common. This is all data you're going to see from the UF. When you look at all the surgeries, all type of surgeries, you can see that even OBGYN, that where you usually do not think about AKI, it's up to 10% of patients. We published a paper on that. Especially after gynecologic oncology cases, it's very common and bad prognostic sign. And then as you move forward, you can see the surgeries that are very high risk for AKI, like a cardiothoracic, vascular, transplantation, and urology. Now it is, yes?
This AKI, the definition has been what?
KDIGO always.
KDIGO.
I only use KDIGO. Like as a nephrologist, you need to use KDIGO, right? So it is often subtle, meaning that majority of AKI cases will be stage 1 and 2, right? Mild to moderate AKI. Severe AKI constitute only a small portion of AKI, and dialysis requiring AKI constitute maybe only up to 8% cases. So as you can see here, stage 2, stage 3, mild to moderate AKI. Awareness for AKI is low. I'm sure you are not surprised with that. If you look at the prevalence of AKI using KDIGO, AKI criteria in vascular surgery for de novo AKI, and then when you look how many patients have AKI in the discharge summary, it's a very small proportion. What's fascinating that even patients who had stage 3, meaning tripling of their AKI, only 40% of them will ever have a mention of AKI. So if you don't see disease, if you don't mention, you will never know you have disease. And that's not surprising that only 11% of AKI patients ever get serum creatinine follow-up. So, we really are dealing with a disease that is not recognized, not even among our colleagues. Well, now I'm going to take you, so we all use, serum creatinine is the most commonly used lab test to define AKI, right? The KDIGO use change in creatinine relative to the reference value. or urine output criteria. Urine output criteria is probably most commonly used in ICU. However, on the floor, it's very difficult to obtain hourly urine output. So we all rely on changes in creatinine for definition. Now we were interested in looking whether, looking at the change in creatinine, most of the time we only define stages as the severity of AKI. What's the maximum stage you achieve in AKI? What we are often not so interested in, and I spoke with fellows of that all the time, is like, what's the progression of the AKI? Is it resolving? Are you recovering? Remember the KDIGO defined recovery at the end of the episode as a return within 50% of your reference as a complete recovery. So if you don't return within 50% of your reference creatinine, you only partially recover. If you don't at all recover, or you stay on the same stage, or you become dialysis dependent, that's considered as a no recovery. But we looked backward and we said, well, can we combine both? If you combine both magnitude of AKI with the recovery at the discharge, do you get more precise in prognostication of the outcome? And does it matter whether you stay where you are, or you just go a little bit or come back? Is there any interplay between recovery and magnitude of AKI? So this is a group that I work with. These are engineers at data science. We used a complicated mathematical approach to account for both, for the changes in creatinine as a time series, meaning every value was considered like a continuum, and then we tried to plot relationship between maximum creatinine considered in relation to your base and your last creatinine. So really what you see here is that, so I put a line here, this is like 50% of your return, okay? So this is all relative to patients who never change their creatinine. So if you look at average mortality risk, so that's very interesting. If you never change your creatinine after surgery, you actually have a survival advantage. That's very interesting. So that means even little change of creatinine is actually bad for you. Now, if you think about it and think that these are all about 50,000 surgical patients, most of the patients get a lot of fluid, right? But we don't account in the regular practices, we don't correct for fluid administrations, right? So there are formulas that account in a change in creatinine depending on how much fluid you get. So there is some dilutional effect. So if you consider that you get a lot of fluid and you really have healthy kidneys, perhaps you should never change your creatinine, right? After 10 liters of fluid, your creatinine should not go up. So in the cohort, the average patient, actually, if you take average patient who never changed, that is a patient who does better than others. So any change actually was relatively not good, right? But what is interesting is if you take any stage of AKI from 1 to 3, if you closer you return to your baseline, better you do. So recovery is incredibly important. Reversal of AKI is incredibly important dimension of AKI. And ACUTE is publishing guidelines that I participated that will now define actually persistent AKI and acute kidney disease, depending on how quickly you reverse your episode and where you are at the time of the discharge. And you can see here, if you had a complete recovery still, even in a stage 1 AKI, you are still in a certain disadvantage to the patient who never had AKI. So it doesn't really protect you. And this go back in a study that I did with Mark. This was a project that was done when I was a fellow. We look at the 10,000 patients with the surgery, and we initially wanted to send them in a letter and ask them to tell us how they are doing, and then nobody responded to a letter. We got maybe 10 letters from 10,000 letters we sent. And it was a waste of money, right? And at that time, there was no EPIC. You have to understand there was no EPIC, So this was 2010 cohort. So I got a resident in anesthesia who was in trouble. He was on probation. And they said, okay, he was from Turkey. And they said, you want to work with him? I said, that's fine. So Sinan went for 1 year back and every record and downloaded every creatinine for 10,000 patients. That was a lot of work. So then we took that and we staged the patients. So why is that important? Looking in administrative database, right? So you can go back. There are many papers that look in administrative database. Using codes, ICD-9 or 10 for that matter, codes is useless for AKI. As much as for CKD, maybe a little better for CKD, but not good enough. Sensitivity of ICD-9 codes for AKI is about 20%. For CKD, it's not much better, but it's a little bit better. That means that we do not identify very well mild to moderate AKI or stage 3 or stage 2 CKD because it's not coded. you saw the awareness. If the awareness among physicians is low, then you can imagine among coders is even lower, right? So if you look at the prevalence of AKI, if you look only at a dialysis-dependent AKI, then it's a little bit better. That's the study that was published in JASON by the group of Shu in San Francisco. But for the mild to moderate AKI that does not require dialysis, you cannot rely on administrative data. You need creatinine data. So we look at that. We use that study. We linked our records with the death index, and we look at who died. And here's the paper that was published in the Annals of Surgery. Part of the graph where we actually adjusted the multivariate analysis for other complications and showed that if you have AKI, even if you completely recover, you are at a long-term disadvantage. Right? Papers after this was in 2009. There will be papers afterwards that will show that will replicate these results. That will show that you are more likely to progress to CKD, and now that's well-established fact. At that time, it was really hard to accept this, believe, even among nephrologists. I think we all believe that now. Now, at that time when we wrote that paper, one of the questions was, so why do these patients die? And we didn't know at that time. We did not have a records on the cause of that. So this is the study that was published this year in Annals of Surgery and also in the JAMA Surgery to kind of close that loop. We actually took now data between 2000 and 2010. This is about 50,000 patients surgical. All of them, we look for AKI and CKD and end-stage renal disease, and then we linked the data with USRDS. We linked it with the death index and the Florida Bureau of Statistics and looked for the cause of that. And this was done using competing risk model. This is a little bit different statistical method that you actually account for other causes. So we asked, we look at the cardiovascular specific mortality and showed that AKI actually is associated with increase in a cardiovascular specific mortality after surgery that is comparable to CKD, right? These are the patients with AKI. Most of them have de novo AKI. And then you can see here that if you have AKI with CKD, that risk goes tremendously up, right? And then you have ESRD, we all know, very high. This is a cumulative incidence of cardiovascular mortality adjusted for the baseline characteristics. What I am sure you are interested also is what was AKI to ESRD risk, and here you can see that progression to ESRD after AKI with no CKD is significantly higher than the regular patients that never have AKI. But if you have AKI with CKD, look at that risk, it's tremendous. So really patients with CKD who develop AKI should really be a bit under microscopy for follow-up. They had a very high risk for progression to end-stage renal disease, and you can see here, if you stage them by stages of AKI or CKD, how that risk go up for the progression. So this is something that I think that nephrology needs to attack. Another component that we were also interested in is, well, like mortality risk is, we are all accepting that now, even short and long term. What we also wanted to show is that the cost is tremendous. And this is the study that will look at the cost of AKI in comparison to other postoperative complications like mechanical ventilation, sepsis, cardiovascular, and so on. So we use adjusted cost model and say if you have AKI and then you adjust for every other complication you have, what's the incremental cost of your hospitalization? So you can see here the cost goes between $9,000 to $26,000 in addition to everything else just for AKI. And I didn't put here the interesting slide that shows like if you have sepsis and you don't have AKI, there's an increase in cost. Now if you have sepsis and AKI, it's not like sepsis plus AKI cost. It's like a multiplied cost. Now, so I always tell my fellow that when you have AKI and more severe it is, it becomes a glue for badness in ICU. Everything else starts falling apart. Other organs, other complications are more likely. Other errors are more likely. And we'll talk about it more. So this is just a brief summary of the things we've done in the last year. These papers all come in the last 2 years. I think they're important to close our view of AKI as a surgical complications. And I'm going to move now on risk stratification. That is now our next kind of big quest. So, okay, so now I think everybody's convinced, at least here in surgery and anesthesia, that AKI and CKD, we need to think about it. But how do you identify patient at risk, right? How do you say that somebody will be at risk for AKI ahead of the time when you can actually do something? Because you can do things in operating room and early in the ICU. So let's go over key points that we want to talk about here. First of all, risks for AKI can be quantified using clinical data only. These are my personal beliefs. Risk assessment for AKI can be improved using biomarkers. AKI can be prevented. AKI progression can be mitigated. That's another goal we need to have. AKI effect on other organs can be ameliorated. That's third goal, I think, as a critical care nephrologist. And then AKI recovery can be facilitated. I always emphasize that on the rounds with my fellow. We need to know, I think if you're a good critical care nephrologist, patients should not leave your ICU on dialysis. I see that as a personal failure. Right? So, we need to do everything we can that they never end up leaving this hospital on dialysis, or for that matter, dying on dialysis. So I'm going to go back now, and now we're going to think about paradigm. So when you assess the health, and I'm becoming more obsessed about it, how do you assess the health? What is health? Like, we define health as a lack of disease, right? Well, that's horrible definition, right? It's like an exclusion, right? So if you think about it, how you go from being fit, frail, to failed and dead, right, in your lifetime, and how certain systems go down, right? I'm start thinking about how kidney go through this paradigm. And so if you go down, when you are very young, I would say, you have acute episode. You have hospitalization, you have trauma, sepsis, something happened to you. You have ability to bounce back, right? But that ability, with time and aging, go down. So your bouncing back is not from a starting point. And I think that's how you progress to death, right? You go from fit, frail, and you go back as you get older. You are starting lower, and you're coming lower and lower, and then sometimes you never come back, right? You work in ICU, you see that all the time. You see this paradigm like accelerated in front of your eyes, So renal sofa. So I'm going to tell you a little bit about ICU, how intensive this thing. So we like to think about failed organs in ICU. And it's a great place where you can see these major organ failure, right? So SOFA is a sequential organ failure assessment score that we use in ICU, where every organ gets a certain scores, and you are trying to define dysfunction and failure. So if you have a hypertension, that's a SOFA of 1. If you need pressors at a certain dose, that's SOFA of 2 for heart. If you need high dose pressors, that's SOFA 3. For lungs, it's a PF ratio, right? You have a less than 300. If you need ventilation, you are now in dysfunction, in a failure. If you need ventilation, your PF ratio is very low. That's advanced failure of the lungs. Same for GCS. This is how we use SOFA for kidney. Now, renal SOFA is a horrible score. Like, it's almost nobody wants to use that anymore if they are in the 21st century. And why? Okay, so you need to have dysfunction, your creatinine needs to be 2. Well, if your creatinine is 2 in ICU, well, that's very advanced, right? That's not dysfunction for me anymore, right? So you can see, okay, absolute value of creatinine means nothing, especially in surgical ICU where you have people with no muscle mass, no nutrition, advanced liver patients who have no creation of the creatinine, sepsis that drop your creatinine production, bad. Okay, so this is good, dysfunctional, fail. Okay, this is bad, right? And where is that on this scale? I mean, who knows? So then, okay, how about kidney SOFA? If they say, okay, if I put KD, go AKI now, and I add CKD, right? Because how can you be 0 if you have CKD? If you have CKD in ICU, you are not normal kidney, you are not green, right? CKD patients are not fit. Their kidneys are not fit. So you can't think about them as a healthy people. I wouldn't, right? That's maybe better. But can we do better than that? I think we should probably using precision medicine. So we need to be more precise to define kidney health. So let's go now on ADKI, right? I don't know. Some of you who follow ADKI guidelines, this is one of the ADKI slides in one of the 2013, trying to incorporate biomarker, so damage and function markers, right? That's how we think about AKI. Damage biomarkers like ANGAL, and others, and then functional biomarkers like creatinine and cystatin C. So they propose the paradigm change and say, okay, we can actually think about no functional changes and functional changes with creatinine positive. In a no functional change, they say you can have no damage biomarker and no functional, so that's good, right? Then there will be a group of patients that will have no functional changes, no creatinine, but they will have biomarker for damage positive, right, in the urine or the blood. And they're going to call the subclinical AKI. And then you would have patients who had loss of function but no damage biomarker. They've got called pre-renal azotemia under codes because I do not like that term. And then intrinsic AKI, all quoted, right? So that was this paradigm of damage plus function triangle. So, okay, well, I'm going to challenge even this one. I'm going to tell you, okay, so let's think about it. So this one. So if you have no damage by existing biomarker and no functional change, where are you on this scale? You can be anywhere between here and here, right? That's a huge. You have a huge range here. So where are you on the health? Meaning we all know that there's a functional reserve, you know, that you don't use, but you don't know when you see a patient, where is this patient in this triangle? How good is his functional reserve? Dr. Ronco is now measuring functional reserve before surgery. We are proposing to that here, before and after, especially for elderly people, because you cannot at the current time assess functional reserve using just static marker like creatinine, even GFR. Okay, if you have damage but no functional, where are you here? You can be even deeper down. No idea. Okay, what about here? Loss of function without damage. Again, very wide range. You can be anywhere here. And then here you can be deeper, but you are still in a huge range of your health. So here I think what we need is better biomarkers. Here we need another dimension, and that will be recovery. Not just damage index. You need recovery index and chronicity index. And at any given time, you need to ask yourself, where is my patient on these three trajectories of, or dimensions of kidney health, right? So if you think about trajectory of critical illness now, this is how I think about it. So you have patients before they come to you. They are either healthy, meaning they have no disease as of now that we know of, or they have some chronic disease. There is no other option in life, I think, as of now. Then you get them either in medical ICU or surgical ICU, right? In surgical ICU, you're going to have surgery with no complication. You're going to have surgery with complication. You're going to have trauma or some pre-transplant terminal condition. These are four most common causes in surgical ICU, right? Then in medical ICU, you're going to have some severe acute exacerbation, some severe infection, new multisystemic disease, and some exogenous toxin. Right? These are four categories. Okay, so this is acute stress now. Now, when you exit ICU, you either die. Well, there are very little options. You either die, or you leave with worse chronic disease. Or that means if you have chronic disease before. If you were apparently healthy and you die and you leave, you either die, you exit with a new chronic disease, or you exit with less health. In my personal opinion, you never exit sane. It's almost impossible leaving ICU healthy as you were before. There is no way you do that. Okay, so then what do we need to do in terms of kidney? How do we assess kidney from there?
Just click on
This one. Okay, that's backwards. Okay, so if you are my patient in ICU and you tell me, okay, doctor, how are my kidneys doing? Simple question. How are my kidneys doing today? What do I need to know to tell my patient where is he on this scale? So here's all the questions. First, I'm going to ask myself, so what was the kidney health for this patient? What do I have right now to somehow assess that kidney health? Well, think about things we have right now. We have things. It's not that we are completely not possible to say something. We have risk factors for CKD. We have estimated GFR. We have albuminuria. We have renal ultrasound. We can look at the signs and echogenicity. We can look at the resistive index. We have renal reserve, ability to functionally stress kidney and tell what's the functional reserve. That's the first thing. So looking at the kidney health, I'm going to say, okay, what's the resilience of these patients towards this acute injury I'm imposing on the patient? Then I'm going to think about what am I doing to my patients? What are my exposures? Can I measure the magnitude of my exposures? What is their magnitude? What's the duration? Is there some specific site of damage that these exposures are attacking? Then I'm going to ask, okay, can I measure stress at the kidney at this point? After all of these things that was done to my patients. And then if I can measure the stress, can I just measure also intensity and location of the stress? Then I'm going to ask, okay, now I'm going to do something. I'm going to give fluid or pressors or something. What's the response to therapy? What does that say to me about my kidney? then I'm going to say, okay, after all of this, what's the damage resulting, and what's the magnitude of damage, what's the location and duration of the damage, and then I'm going to say, okay, in parallel with damage, we know the repair goes in parallel with damage. What is the repair condition right now? Is this starting to repair? And then after addressing all of these questions, I'm going to say you are somewhere here. And I'm going to have multiple dimensions. Okay, well, that's the goal. That's where we want to go. Where are we right now? So this is the first thing that we start working on this. This is, we said, okay, can we use clinical data collected as a routine care that are there sitting for us to do clinical risk assessment, but we want to use what we have. We don't want to spend any more money. We want to do no additional tests. We want to be able to apply to every patient, and we want to be automated. We want to take doctors out of the equation because doctors are not very good for this, right? So we call it Gator Risk Kidney, stands for guiding assessment and treatment in operating room, right? So we are trying to do this for every complication, not just for kidney. So this is our risk score. This is very simple preoperative risk score. Now, you will not believe it doesn't use anything fancy. It does use creatinine and albumin, and it uses where you live and who you are and what diseases you have. So it calculates this score as a probability for you to have AKI after surgery in the first 7 days, before you go to surgery. So, and you can see here, we use some cutoffs to help and define groups, and if you have a high risk score, then your relative risk for AKI is 7 times higher than for lower group, and then among those patients, 78% of them will develop AKI. Simple, it is just data that is sitting there. Data that sometimes you don't think about, right? What was interesting, I'm not going to go talk about that score in the details, but I'm going to show you something interesting for nephrologists. When you now take GFR using creatinine that you had before your patient go to surgery, and then we look at the subset of patients who had urine data, right? And we just look at the either dipsticks or whatever protein assessment they have. And we look at this category and then missing creatinine. What you see here, first of all, this is the risk of 1, right? So if you have no risk. Now just notice where does it cut the threshold, right? What is the GFR for 1? It's not 7, it's not 60, right? 60 is not good GFR. That's a non-healthy GFR, right? So majority of our patients will be healthy people, right? So we go, as nephrologists, we put that 60 somehow as a cutoff, but I think that's a very, very low cutoff. Somewhere around 100. Now I will challenge also to you to look at the patient in the Lancet that came a couple years ago and look at the longevity. And major factors that determine longevity in general population were proteinuria and estimated GFR, right? And they show that the neutrality about GFR of 75, right? Not 60. So I think 60 is such a wrong threshold. But for any given GFR, more proteinuria you have, risk go up. So if you have a patient that for some reason have proteinuria on dipstick, that patient is more risk for AKI. And that's known in a cardiac surgery. EJAS will tell you, like, microalbuminuria is a preoperative risk factor. For, I don't know why, but it might not be necessarily related to kidney. But I think it's an important factor. So precision medicine using clinical data is paradigm that we put forward, and that's the paradigm we use for my R01, is that we will start from separated clinical data from different sources now in an integrated data that will be electronically available, that you can apply analytics to extract knowledge, use that knowledge to translate in some targeted clinical intervention. So meaning when you now have everybody who come for surgery and you identify somebody at the risk, you have enriched your population. This is the population now, then you need to apply your biomarkers because there is no need and it's incredibly costly to test everybody with expensive tests. That's not a good medicine. Okay, so this is our group, PRISMA-P, Precision Intelligent Systems in Medicine. What we really want to do is to use matrix to understand health, right? It's kind of futuristic look at that. This is a part of my team. Dr. Rashidi, Biomedical Engineering, she's an expert in a data mining and sensor data. Daisy Wang, she's a professor in computer science. She works on integration between human and computer intelligence. This is Gigi Lipori. She's a chief data officer at the UF. Tejjan was my postdoc. She's a research assistant professor. She's a statistical expert. She works with me. Andy, my co-PI in electrical engineer, he is expert in big data analytics. He's going to build this system. Dr. Pardaos is an expert in data optimization with Dr. Momcilovic in industrial engineering. Dr. Hogan is a director in the CTSI of bioinformatics. He will work with us on a data harmonization. And Ashkan Ebadi is a postdoc with Rashidi, who I'm recruiting as a research assistant professor. He's also data scientist. He will be working with Tezcan and me in my group. So this is the little picture of our proposal. It's called Integrating Data, Algorithms, and Clinical Reasoning for Surgical Risk Assessment. We call it Idealist Study. This is kind of what we want to show, is that here you are coming for surgery in some pre-op clinic, all your data is in the cloud. We're going to take that data, develop the score that goes in pre-op assessment, doctor assess, use the score, he also gives the feedback. You go to surgery, things happen to you. Those things are monitored in surgery intensively with the monitors. You're going to take everything from the surgery, synthesize it with this other score, right, and other data, and produce another post-op score that goes to another set of doctors. They're going to give feedback. You're going to go to your room. We're going to collect everything else back to cloud. You're going to leave, and then we're going to follow you. That's how this is supposed to work. So really this grant is about real-time electronic health records analytics and high-performance computer synthesis. This is the system we propose to build. It's a lot of softwares together that will take the data from IDR and the EPIC and then integrate in this repository and go through all of this, produce mobile apps that we will exchange with doctors and collect their feedback. And train the system in real time to become smarter, looking at the data and the doctor's opinions. And we apply active learning, meaning that doctors will get the risk. It will provide feedback both for features and the risk, meaning he will comment whether he thinks the computer will produce score as a probability, and then we'll also tell doctors, this is why I think this patient is a high risk, and we'll ask doctor to agree or disagree and also provide additional features. That goes back to computer, and it learns in the real time. This is machine learning, so it learns from the data that is happening. This is a clinical study for 29 months. We will recruit doctors, actually. There are no patients here, anesthesiologists, intensivists, and surgeons, and then kind of test them, and it's all happening behind. We don't see the data. We will download the data as a limited data set and de-identify it at the end, and we have a big data set. Okay, so that's the clinical risk. I'm going to move forward now and talk about biomarkers a little bit because I was involved in that work too, right? This was a study in 2013 that talked about discovery and validation of cell cycle arrest biomarkers, TIMPB, tissue inhibitor metal proteinases, and insulin growth factor binding protein 7. It was a multi-center study, 27 center, Europe and US. We were a #1 recruiting center, UF. We were #1 in the United States. And the study validated this the combination of these biomarkers that are cell cycle arrest proteins, and we believe that they are produced in tubular cells in response to the stress. So we call them stress biomarker, tubular stress biomarker. They were positive before creatinine changed, and they were able to predict moderate to severe AKI, stage 2 or 3. When tested with other biomarkers in parallel in the SAPPHIRE study, they performed better. You can see other urinary angles, cystatin C, KIM angle, IL-18, GSC, and FABP. These are AUCs. You can see how the difference. The test that then validated biomarkers that, again, we were a leading center, was published in the Blue Journal. In this study, what we did, and I think this is important to review this study because NephroCheck is now approved in Shands, and we brought the test at the UF. We are one of the first center to have it for limited use. We conditioned the use, and I'll tell you why. So this study enrolled 420 critically ill patients, meaning you have to be in ICU. All of them had cardiac SOFA greater than 1. That means they have some hypotension. At some point, they have blood pressure drop, less than 70. They had respiratory SOFA greater than 2. That means they have PF ratio less than 300. And they could have stage 1 KDIGO or CKD stage 1 and 3. So the test was done 24 hours within ICU admission. It was predicting clinically adjudicated moderate severe AKI in 12 hours from the test by 3 independent nephrologists. And again, the baseline was KD go 2 or 3, that is doubling of your creatinine or less than 0.3 milliliter per kilogram per hour for more than 12 hours of urine output. So again, in that cohort, in prospectively test was validated, it performed better, it performed well. This was AUC. And then if you had a positive test greater than 0.3, your risk for AKI was 1 in 3. If your test was negative, this was 1 in 25. So test was FDA approved for AKI risk stratification, and now it's available. Now we pilot tested here in the surgical ICU, and we proposed the test has to be used with the clinical risk stratification and standardized assessment and management plan. So we call that SCAMP for AKI, and it's really algorithm how you apply this test from the beginning to the end. Because this is not for nephrologists, right? You understand this is for patients who don't have AKI yet. They are at the risk for AKI, and they probably most of them don't need nephrologists, but it's like a primary prevention for cardiac disease, right? You are not giving, the cardiologists are not giving aspirin or statin. Primary doctors are. Primary doctors in ICUs are intensivists for ICU patients. So we have developed this protocol where you have a little note, every new admissions get a note in Epic, it's called Neph note, you type .Neph note, it produces several things related for your GFR. Do you have history of CKD? Do you have oliguria? Do you have albuminuria? Did you have hypertension, sepsis? All these risk factors. And then if your score is greater than 2, you get tested for NephroCheck. If your score is less than 2, you don't. Because you don't have to, right? And then if the NephroCheck is positive, then we say, if it's negative, let's start with negative. Most of the patients will have negative tests. Then you can say, it's usual care, you can do whatever you want. Kidney is not your focus. If the test is positive, we shall initiate CPR, that is cause prevention of reassessment. The prevention is A, B, C, D, E, and it's really A, B, C, D, E, and you would be surprised that A, B, C, D, E is not done all the time, right? And that's assess urine output, start looking at the urine output, repeat creatinine in 12 hours. You need to see where is it going from your first assessment. Optimize blood pressure. That's another topic. What's optimal blood pressure? It's not the same blood pressure for every patient, right? Optimize circulation and fluid. Adjust your drugs. And again, I'll tell you that the most dangerous drugs for patients at risk for AKI and CKD are not nephrotoxic drugs. These are opioids, benzos. Because these patients get too much of them, get reintubated because they don't breathe, and then evaluate again. Very simple. Then you reassess in 12 hours. You can now look at whether patients are getting it. So you got rapid reversal versus persistent AKI, 2 different paradigms. You're going to approach them differently in 12 hours, right? If your test, so then I think we're going to talk about paradigm of persistent AKI. This is when we want to involve nephrology earlier, right? So this is what we have seen using the test. You get about 35 per week admissions in surgical ICU. Low clinical risk, about half of them, medium to high 50%. Half of them get tests, 40% get positive tests. That ends up being about 7 patients per week get positive tests. We are writing a paper on this to show like how many progress. That's for another talk, but I'll give you some examples. So what do you do with the test? I always get this question when I give talks to intensivists. Here's the common scenarios. These are real things. So here's a 70-year-old gentleman, complex spine surgery. He has a history of CKD. Baseline is 1.1. ICU admission, he comes with 1.3 creatinine. This is for non-nephrologists, right? He's intubated still. He's hypotensive. He got like 8 liters of fluid in the OR already. He has no cuff leak on the vest. That means his airways is swollen. He had too much fluid. His score is 4, right? And what are you going to do? Are you going to give him more fluid? Creatinine is up. Are you going to give him diuretic? What are you going to do? Give him diuretic. What would be the first thing you will do for this? Here's a similar patient. So you got 70 years, people, ICU admission, same creatinine, 1.3, no previous history of CKD. You don't know the reference. Obviously, it's too high for 72, right? Exposure again, hypotension. He got nephrotoxic drugs. He got contrast. His score is 5. He comes to ICU. What do you do with his creatinine? You give more fluid. Is this a risk? Is this AKI? What do you think? Here's 80 years old. Again, CKD, vascular surgery, ICU admission. Creatinine is close to 1.3. Baseline is 1. He's all urine for 3 hours. He's making about 30 cc of urine for 3 hours only. He also had hypertension, nephrotoxic drug. His scores is 7. Now, what would you do with this patient? Fluid, diuretics, nothing, right? This is not an easy question, right? Even for nephrologists. So, because you don't want to, sometimes diuresis, most of the surgeons will not give diuretic immediately after surgery, right? There is this worry about, making patients hypotensive or volume depleted, right? All of these patients got like 7 liters in the OR. So I will tell you that most of intensivists will give fluid as a first response. First response in ICU is fluid. You have hypertension, fluid. You don't make urine, fluid. Creatinine is not fluid. Well, all of these 3 patients had tests that was negative. So you know what? All of them, we gave them diuretic. Next creatinine for all of them went down, right? So what we avoided really is what we now know is the next dimension of AKI, that's a fluid overload. Tremendous risk factor for adverse outcomes after ICU admission. Okay, so what's next, right? So what's next for us? So we are proposing to create data analytics in critical illness as a clinical group, not as a research group, that will bring individuals from surgical department and medicine and anesthesiology with objective to create process of data-driven health outcome reporting. So what we want to do is, and I've got a quality grant to create Epic AKI app that will actually track in real time AKI KDIGO. So you will get, like you get EGFR, you're going to say little warning saying your patient is having AKI stage 1, 2, or 3, whatever, based on this criteria. That unfortunately, recent study in Yale did exactly the same, and well, guess what happened? They sent alerts to doctors. Your patient has AKI. 1,000 doctors got this alert, 1,000 doctors didn't, and nothing changed. They did still the same things. It's not enough. Knowing is not acting, right? But that's the first step. We want to be able to track our outcomes in real time. How many patients have AKI, how many patients have sepsis, and so on. Proposing that group then will be, we will have a downloaded data that we'll use for outcome and quality improvement, and then we will have, with the de-identification process, we will have ideally this data set that is temporal, it's a limited, and then finally gets shared data for research from all the data collected as a routine care through the de-identification process. Expensive process, but we want to invest in this because we believe that a lot of this data can drive clinical research and also translational research at this institution. In the research, as Mark mentioned, both Mark and me, we have a project on the kidney in sepsis where we are developing urinary signature of sepsis, where biomarkers looking at messenger RNA, metabolomics. We are collaborating with P50. We want to develop a pragmatic trial where we're using cloud-based electronic health records, phenotyping and risk stratification. We will be able to initiate standard versus guided standard of care, meaning versus guidelines-based care for AKI. I want to warn you that there is an ongoing trial in ESRD for the same issue. It's a pragmatic trial of several end-stage renal disease centers that they are doing standard of care versus guidelines-based care for ESRD. I learned that there is one that is just funded for CKD called PISIS trial. Same pragmatic trial, CKD guidelines versus standard, and we are contemplating with several other centers guidelines versus standard for AKI is another pragmatic trial that will require this type of data sharing in the cloud. And obviously, precision medicine will proceed from EHR phenotyping now to genomics, transcriptomics, proteomics, metabolomics, all these fancy things that are incredibly expensive. But they can start adding new dimension to selected group of patients, but not to all of our patients. We are focused on physiologic streaming data, meaning things like heart rate, your ETCO2, SpO2, this physiologic data as a phenotyping physiologic response to acute stress. And our current collaboration here, you can see we are on a P50 with sepsis in critical care, connected with the Piper Center for Induced Frailty. Tevjan is considering her K award or developing phenotype for the induced frailty and sepsis. R01 is Dr. Moldauer lab for genomic validation trauma. We are working with him on that. And then our idealist study really intersect with both P50 and genomic validation trauma. And you can see here other R01s connected to the surgical team that Dr. Siegel and I work together in a circ. And this is my blog. It's called Kidney Love. I like to write things about life and kidney. That's all I have. I hope it's not too much.
So that was a really wonderful talk and great overview. I will disagree with one thing you said, that that we don't want to be involved with the in screening patients at risk for AKI. When you think about where we are in a healthcare system, that in the future we are going to be asked what value do we bring to the healthcare system. And the value we could bring is a huge value, as you said, $9,000 to $26,000 for each episode, is preventing AKI episodes, or preventing someone from needing dialysis beforehand. So I think that is a space that if we don't claim it, other people will claim it, and we should be there because it will be really important when we're going into the contract negotiations with hospital systems, no matter where you are, and they say, you're just bringing cost, and so you have to think about the value, and this is a great way to bring value as we switch from a pay-for-service to ACOS system.
Absolutely. So now this is a little secret. So I showed you this data on earlier stratification. So I think that the way how I actually agree with Mark, he's stealing my secrets. But when you take, let's say you have 100 patients admitted to surgical ICU, right? Now we cannot see 100 people, right? We have no workforce of that kind. Of those 100 patients, let's say 50% will be at the clinical risk for AKI, and you test them early in admissions, and you will be able to exclude those with negative tests will be excluded, right? They are not going to be attention for you. So that, I think, is the first value of the tests like that. Like the certification starts with exclusion, really. That's the number one test. Exclude those who don't need extra healthcare attention, because extra healthcare attention is bad for a patient. I can guarantee you that. Now those who have positive nephrocheck, right? Those who have positive clinical test and they have positive nephrocheck, that I can tell you that is the most challenging group of patients. That most of intensivists really don't know what to do. And I have seen my team struggling there, right? It was very good. Okay, they don't have it, they're happy. So let's say that we are dealing with the 20% of admissions then, of in ICU. That is still a large number of patients, right? So it's still a large number of patients to introduce full nephrology consult for that, right? But we have thought about that together with my colleagues, whether we can think about simplified, targeted, nephrology-guided prevention team, right? So you call it prevention team that not necessarily need to be full-blown nephrology fellow attending, but maybe just extender-based team that will go targeted, standard-based, protocol-based intervention in those patients who have both clinical risk and have positive biomarker. And then engage very early. Some of these patients will progress no matter what you do, probably a third of them, because they have a huge insult, right? They need us, because for those patients, we will need to initiate renal replacement therapy based on different standards than now. You need to come earlier. We are coming too late in ICU. Oh, that's no question about that. Yes, Dr. Ringo.
Taking off on that, I think the thing that was particularly interesting about what you said was that at Yale, where they characterized and they had an index of whether the person had AKI or an index high risk, that it didn't make any difference.
They didn't have risk. They only had AKI, yes or no. So they can only say diagnostically.
But even that, I mean, that's even more profound. I mean, they've got AKI.
And nothing was done.
And nothing was done.
Because it wasn't it was just regular doctors. They really.
That's the point.
Yes.
That's the point. If you had characterized that by different categories, I wonder if you would have had some groups that would have responded, maybe internists, maybe intensivists, or other, we won't mention those that we think might not respond to changing their therapy. I think
They look, but
that's part of the issue. But there's a more fundamental issue here, and that is you were making the comment about most of the intensivists give fluids, and you're resistant to, you think that that's oftentimes not beneficial. I would agree if they give 5 liters of fluid very, over a long period of time, and they just produce hypoalbuminemia, fluid congestion in the lungs. But if they think, like you were suggesting, physiologically, and see whether the person is volume depleted, volume replete, et cetera, but that's not being done. And that's the type of thing that a nephrologist will be much more attuned to wanting to optimize in that individual. A lot of those things are very difficult to develop protocols for because everybody's a little different, if you see what I'm saying.
Right. And when I say let's say scams, right? So, standards is also, goal-directed therapy, it's a gold mine of intensivists, right? We all believe that we physiologically assess preload dependence, right, in ICU. And complexity here is none of these patients who end up having AKI have normal vasculature, right? So the fluid does not necessarily do what you think it's going to do to that patient, right? So that's exactly the point that you are making and Mark is trying to emphasize, that in a certain group of patients, our involvement early might be beneficial. When you have one team focused on that organ, sometimes just looking helps, just being there. Saying, no, do not do CT now with contrast, because it's not absolutely necessary. But, this patient has risk, high risk, and you are looking at the biomarkers 10. You're going to give the contrast, and you're going to give those of vancomycin they don't really need. Next day, that creatinine will double. I can guarantee you we had cases like that, right? That's a cumulative exposure afterwards in high-risk patients that make them really progress. So that's where the team plays a tremendous role, having a team like that. Now, how do you bring that team into play, right? Because you can't tell people you need cold nephrology. They will object that as a part of the protocol. But making some joint quality intervention or something, I'm still thinking about that because they are open. They have came to me and said, if we want to improve that, because they want to improve that, how can we together develop this pathway that is joint decision? When we have these factors, we're going to intervene as a team.
Basically, you're saying that you want them to think like a nephrologist,
yes,
not realize that they are.
Think, and then when they see that they're exceeding their capacity, they're going to call you, right? Now think about it. Committing to that is a big deal because they work day and night and weekends, right? Because if you're going to be there all the time, you need to be willing to be there every Saturday, Sunday, and night. Right? It's a 24/7 operation. So, that's why I think you need to be smart to use technology, maybe different healthcare force, right? Not necessarily doctors, are too expensive. But, right, they are, but, we use extenders and ARMPs a lot. You can use technology. We can use intensivists. So I think we need to be innovative. But I think we need to do something because that's how we will learn this. That's how the patient will know you are his doctor because these patients leave. They were on CVVH. They leave and they say, I didn't know my kidneys were sick. This is the first time I heard about it. This is unbelievable. They leave. They never see nephrology. That is wrong. Go ahead.
Yes, I was wondering, in this risk assessment, you didn't seem to mention past medical history, whether hypertension, yes, no, diabetes, yes, no, hypertension and diabetes, yes, no.
All of that is in the score as a part, yes. I didn't show you components. We put all history in the algorithm, of course, to define, pre-existing health. But, the history, what's interesting thing, you would never think about that where the patient live is important risk factor, right? We know more and more that, genotyping is very important because in America, people who live in certain neighborhoods have a different type of health. Where you live shows what kind of health care you have, right? So these factors you don't think when you see scores. And, you know, who is your doctor? All of these things is there. You know, computers see distribution of the population in the past and kind of make some prediction based on that.
I have a quick question.
Yes, Dr. Gopal.
In terms of using this EPIC data in real time, how accurate is it, or what parameters are being used to assess volume status? Because that is something which is very difficult to assess.
Right. So for us, for this grant, we are doing only 2 time points prediction. One is before surgery when you're coming from home, and then one is after surgery. Of course, when you are coming from home, we don't have enough data, right? That's another thing you can think about it. If you are high risk preoperatively, very, very high risk, maybe you need a different additional assessment. You know, and that's something that we thought about. Maybe there is a subset of patients who needs renal reserve assessment. Post-operatively, we have data from the OR, and it's accurate. That's all captured in operating room, very, very closely in the SI system. Thank you.